Welcome back. This is part 4 of chapter 12 on the kidneys. We had just finished up our tour of the nephrons and what the different parts of the nephrons did. We saw the proximal tubule, we saw the loop, and the distal convoluted tubule, and finally the collecting duct. And what happens if we have acute tubule dysfunction. Now we are going to move on to something that we have addressed before, we've alluded to it before, and that is the role that kidneys play in maintaining blood pressure. So I'm going to remind you, when we were in the circulation chapter, we super simplified circulation. And we said that there are 3 factors that we're going to deal with. We said that there's a pump. And then we said there's something that contains fluid. At the time, I used the term tube. I said there's a pump, there's tubes, and then there's liquid in the tubes. Because now we're talking about the kidneys and we're using tubes to mean something else, I changed hoses. So if we're talking about the blood, I'm going to refer to hoses. What I'm talking about are arteries and veins, of course, where the vessels of circulation, and the liquid in the hoses, that's going to be the blood. And so the kidneys, primarily what they can affect is how much liquid is in those hoses by adjusting how much water gets reabsorbed from the nephrons. A little bit, kidneys have an impact on the hoses, how tight those hoses squeeze down. But primarily the effect that the kidneys can have is on the amount of liquid that's in the hoses. So let's take a look. What happens with the kidneys when the blood pressure is too low? So if a patient is hypotensive or hypovolemic, they're hypotensive because they're hypovolemic, one of the first things that happens is the sympathetic nervous system kicks on. It stimulates the kidneys to release one of the 3 hormones that the kidney makes, and that is renin. And I shouldn't have mentioned 3 because there are 3 hormones involved in this system, and they're not the 3 that are made by the kidney. The only one the kidney makes here is the renin. So the renin is this hormone that's part of the renin-angiotensin-aldosterone system. It cleaves, it helps to cut one of the proteins to activate angiotensin. Angiotensinogen becomes angiotensin 1, then angiotensin 1 in the lungs can get activated to angiotensin 2. Angiotensin 2 makes us thirsty, makes your patient want to drink water, bring in more fluids. The other effect that it has is on the blood vessels themselves. It causes vasoconstriction or squeezing of the hoses. And then finally, the 3rd hormone, aldosterone, that's being secreted from the, oh my goodness, adrenal glands. Aldosterone, its impact is going to be in the distal tube. Remember aldosterone, he's going to hold on to the sodium. And after holding on to the sodium, the water is going to follow. That's going to increase the water reabsorption, increase the liquid in the hoses, increasing blood pressure. And then finally, another hormone that's playing a role here, we've mentioned it, and this is where the PP was. Antidiuretic hormone, also known as arginine vasopressin. And why I keep doing this is our textbook only calls it arginine vasopressin. But if you've learned it as antidiuretic hormone, I want to make sure that you get these are the same thing. This molecule is released from the posterior pituitary gland. That's PP. This is the PP hormone. And what it does is it causes the collecting duct cells to put more aquaporins in and allows us to recollect more of the water, hold on to more of the water. And that's going to restore blood volume, or in other words, increase the liquid in the hoses. So that's how we're going to get blood pressure to come back up by the kidneys. Then, if we have the opposite problem, if the blood pressure is too high, they're hypertensive, they have too much fluid on board, there's going to be inhibition of the three things we just talked about: inhibition of the sympathetic nervous system, inhibition of renin release, and inhibition of ADH or ABP release. Here's a good one. The heart can actually produce some hormone. It doesn't have a huge effect, but there are a couple of natriuretic hormones. These were mentioned before when we talked about heart failure, and the heart, it's not strong enough, it can't beat hard enough, and it ends up being dilated. It's in response to that dilation that the heart releases this natriuretic hormone. And I keep saying it very carefully so you'll get what it means. It promotes vasodilation, but the other thing that it does is it reduces sodium reabsorption. Natri, like natrium, the Na of sodium, and uretic, urine. So natriuretic means pee out the sodium. So we're not absorbing it, we're releasing it. When we release sodium, that allows more water to follow. So this is going to reduce blood volume. And if I didn't mention it, the release of natriuretic hormone, I'm going to stop calling them that. I'm going to call them ANP and BNP. These are the molecules that are released from the heart. They're not super strong, but they, again, they're great indicators of heart failure. The fact that those are being released is a great indicator of heart failure. Okay, and the effect they have, again, on the kidneys is to release sodium, let the sodium out in the urine, natriuretic. All right, so now we're going to talk about acute kidney injury. In this case, we have onset of problems very quickly. This is in contrast to chronic kidney injury or chronic kidney disease, but it's really a spectrum. There's no cut and dry, this is only acute kidney injury, and it's completely different from chronic. They have some of the same symptoms, some of the same problems. When do we have a kidney problem that it will come on very quickly? It can result from, this is one of the famous ones, the post-streptococcal glomerulonephritis. This is the one that's more common in kids. So again, streptococcal, it's the strep throat infection, Streptococcus pyogenes, that causes that. When the immune system goes after that infection in some patients, that same immune complex, the same antibodies that go after the strep, start being deposited in the glomeruli and cause inflammation there and the onset of a bunch of kidney problems that the patient never had before. We also see acute kidney injury in our hospitalized patients when they're critically ill with sepsis and hypotension, because there's this big drop in blood pressure that's going to lead to a very big drop in perfusion of the kidneys. And so we're going to see some damage from the hypoxia that the cells of the kidney experience. There are some medications that are damaging to kidneys. There can be trauma. There's myoglobin precipitation. Oh my goodness. I'm blanking on the name of it. I'll come back. All right. Acute kidney injury is generally separated into pre-renal, intrarenal, and post-renal causes. These are not super helpful terms, but pre-renal means the stuff that comes before the kidney. In other words, the blood supply. That's the incoming stuff. So hypotension, a decrease in pressure, hypovolemia, we're going to greatly reduce the glomerular filtration rate. We're going to end up with medullary hypoxia and acute tubular necrosis, where we have actual cell death of the cells in the tubules. Once that happens, then there's actually damage inside the kidneys. It's not just about blood supply. And so once you have damage inside the kidneys, this is referred to as intrarenal This could result from drug toxicity. There's some antibiotics, there's some radiographic contrast media that we have to be careful with, that we have to make sure to not give to our patients who have kidney problems. It could be, as we mentioned above, the immune attack. It could be infections of the kidney. And then finally, what's referred to as post-renal causes. This is stuff that comes after the kidney. In other words, stuff having to do with urine and the structures that drain the urine. So there's obstruction due to a kidney stone, for example, or due to a tumor, either in the kidney itself or in the bladder. Acute kidney injury, typically it's managed if it's really acute and just temporary because the other problem that led to it is being addressed. Then you just manage with fluid replacement as appropriate, treatment of the underlying problems, sometimes dialysis needs to happen until the kidney can recover function. Secondary kidney injury can occur, hypertension, diabetes, we've mentioned these before, some of the autoimmune diseases like lupus. And as I mentioned earlier, these acute kidney injuries, some of them will resolve and the patient goes on and lives a perfectly normal life. But in some cases, because there was some actual permanent damage done to the kidneys, the patient's more susceptible to developing chronic kidney disease later in their lives. Markers of kidney function. So how are we going to assess how the patients are doing? We have mentioned before the serum creatinine levels, that's the creatinine in the blood. And why it's so useful. This is the one I refer to as like the eggshells. I mean, it's waste, not super dangerous waste. It's just typically pretty consistent waste, consistent to the individual. And so using the level of creatinine in the blood and some other information about the patient, their age, their weight, we estimate what the glomerular filtration rate must be in order to give us that creatinine level. So the units, typically milliliters per minute or milliliters per minute per body surface area. There's a bunch of different calculations that can be done, a bunch of different ways of estimating glomerular filtration rate from the serum creatinine levels. If we're not confident in these estimated glomerular filtration rates, we actually might do a direct measurement of creatinine clearance. So we're approximating the glomerular filtration rate a little more closely. This is going to require that we test how much creatinine was in the patient's blood. And then for 24 hours, we collect every drop of urine that this patient produces to see how much of the creatinine that was in the blood has ended up in the urine. That's what we mean by creatinine clearance. And yes, it's more convenient to just estimate it, but if the estimate we suspect is off, then it's best to do this 24-hour urine collection. And then if we're doubting even that, there is a possibility of doing a laboratory measurement of glomerular filtration rate. But as I mentioned earlier in, I think, part 1 of the lecture, this requires intravenous infusion of a marker. So there's something we're going to give the patient, has to go in an IV, we check the level that they have in their blood, and then again, we measure how quickly they clear it. And that's used to validate these estimating equations for this particular patient. And we would only do this if we're very concerned about somebody's kidney function. All right, some additional markers of kidney function. Only one of them is a blood test. The rest of these are all urinalysis. So the blood urea nitrogen, you remember this is just the amount of the amount of urea that's found in the blood. So it's just another marker. It's not it's always reported. It's not always as informative as creatinine, but often both numbers are given. When kidney function goes down, you're going to see an increase in both creatinine level and blood urea nitrogen. Okay, now let's take a look at in the urine. What can we see there? In the urine, what we're looking for is albumin. I'll remind you, albumin is the most common protein in the bloodstream. It shouldn't be in the urine at all. So if we're seeing albumin in there, that means there's already been some damage to the glomeruli. And so we do this ratio of albumin to creatinine, ACR, the albumin to creatinine ratio. Basically, if there's a lot of filtration happening, we want to accommodate for that, if that makes sense. So the absolute amount of albumin, it shouldn't be there, but given that it's there, how bad are things? And so we see, based on how much creatinine is coming out, how much filtration did we have at any rate. The higher this number is, the more albumin you get per creatinine, the worse things are. It means that the glomeruli are more and more compromised. In addition to just looking for the protein, we also do a bunch of tests, usually with a little dipstick. This is urinalysis. We measure the pH, because remember, the kidneys are supposed to be getting rid of some of those excess hydrogen ions. Osmolality, the concentration. Glucose, shouldn't have glucose in the urine unless the patient is diabetic or they're taking this medication to treat the diabetes to pee out more of the glucose. Ketones, it comes up in this urinalysis test. Whether ketones are present or not has a lot to do with what the patient's diet is like. So if they follow a low carbohydrate diet, you may see ketones in the urine and it's not dangerous. If you see high ketones, that's a bad sign. The patient may be heading towards ketoacidosis. We're looking for evidence of infection, looking for protein, white blood cells, red blood cells. All of these can be done with a dipstick. And then a microscopic urinalysis, looking for cells. There shouldn't be cells in the urine. Bacteria, epithelial cells, blood cells, the casts, there's those clumps of cells. I gave you the analogy of like dirt on your floor, whether it's just powdery dirt, you don't know where that came from, or if it's coming in clumps, you might guess that it's out of the sole of somebody's shoe. If you get these casts, that's telling you that this is a cast of like cast iron, like something that's in a mold. This got stuck like in a nephron, and then that got peed out eventually. So that's telling you there's a problem up in the kidney, not just in the bladder. A little staging of chronic kidney disease. It's staged 1 through 5. Stages 1 and 2 are largely asymptomatic. The patients typically don't know unless this gets picked up in somebody's annual physical. These glomerular filtration rates are still good. They're up pretty high, but the albumin to creatinine ratios are also high. That means that these patients are spilling protein into the urine. They should not be spilling protein into the urine. That means you've got some big holes in your glomeruli. By the time the GFR falls below 60, that patient is in stage 3 chronic kidney disease. Depending on who you talk to, some people will say kidney disease is just a chronic problem. It just gets worse and worse and worse and worse. And if it's true, if nothing changes, then yeah, this is just going to get worse. If, however, some of the kidney problems that the people are experiencing are due to especially diabetes, especially to elevated blood sugar. If the person can change things in their behavior such that they get their blood sugar brought back down and keep that under control, and this takes months, but some of this is reversible. Once it gets, dead cells are dead cells. You can't bring them back. But if the cells are just damaged, then you can get some recovery, but something significant has to change. So the blood glucose better get back into the normal range and blood pressure better get back into the normal range. But most kidney specialists will tell you that once a patient's kidney function has decreased to this point, it just gets worse from there. And stage 5, this is known as end stage renal disease. The definite, we say a glomerular filtration rate under 15, but basically these patients have to be on dialysis. Their kidneys are not getting rid of enough waste, and they're not adjusting water volume well enough. It's all the stuff I just said. Stages 1 through 3 generally asymptomatic. Most patients get diagnosed not until they're in stage 3. And then that stage 5, end stage renal disease, it's based on the diagnosis, the clinical diagnosis is based on whether they need renal replacement therapy or renal transplant. Low nephron number is a predictor of chronic kidney disease risk. We don't get new nephrons after birth. Once we're born, that kidney is done. That's as done as it's going to get. And so when we lose nephrons due to disease, diabetes, hypertension, kidney injury, the nephrons that are left over take over. They do more hyperfiltration. But that increased nephron workload can lead to more nephrons dying. And that's why that's the explanation for why chronic kidney disease is often a progressive disease. As a way of thinking about it, you've experienced this with nursing in the last few years. There's a shortage of nurses, and so more nurses are being asked to care for more patients, and that's more of a load for the nurses. And so we're losing more nurses. People are leaving the field. Similar things happening with the nephrons. Some nephrons, if it's not just the nephrons, are a little bit damaged and can recover. If the nephrons are actually dead and they're gone and they're not coming back, then these other nephrons have to permanently take over the job of the dead nephrons, and then slowly we lose more and more and more of the nephrons. All right, so what does this look like for the patient? Patients are dependent on dialysis to maintain their fluid and electrolyte balance. Because they're not able to unload the electrolytes and unload some of the water, they end up with hypertension. They end up with metabolic acidosis. Again, I'll remind you, the acidosis part is the having excess hydrogen ions, and the metabolic part just means it's not due to a respiratory problem. Here's a big one. The patients end up anemic. You might think red blood cells, lacking red blood, lacking oxygen carrying capacity. What the heck does that have to do with the kidneys? Well, one of the hormones that's made by the kidneys is erythropoietin, and EPO. And EPO is the signal that the bone marrow needs to receive in order to produce more red blood cells. And so patients in end-stage renal disease, they're not making enough EPO. And so they have to be prescribed EPO to help bring their red blood cell count back up. And then another hormone-related problem is calcium and phosphate level abnormalities. The patients end up with these chronic kidney disease, mineral and bone disorder, so CKD, MBD. And I'll try to explain it. So it results from a decrease in 1,25 hydroxy vitamin D, which is a mouthful, I know. Vitamin D, as you know, can be made in the skin, but it needs to be activated to 125 dihydroxy vitamin D in order for it to be functional and have the effect it has to have for calcium uptake from the gut If that doesn't happen, if the vitamin D is non-functional, then we don't absorb enough calcium. The patient does not absorb enough calcium from the intake, even if they're supplementing, they can't take it up. And we need calcium, as you know, for the muscles to contract, for the heart to function properly. We absolutely have to have calcium. If you check somebody's blood calcium level, it will be normal. Because I don't know if you know this, but you've got a lot of calcium in your body. It's usually, tied up in bone, but you're going to suck every last bit of calcium out of your bones before you let your heart go without calcium. And so what ends up happening is the patients become osteoporotic. The bones break very easily because so the patient may be consuming calcium, but they're not able to absorb it. So their calcium intake, what appears to be their calcium intake, seems to be very low because they can't pull it up because of this inactivated vitamin D. But their parathyroid gland, these are the glands on the back of the thyroid gland, their job is to tell the body, hey, I need some calcium. Can you take it back out of the bones again? And that's how actually I remember it. Parathyroid's on the back of the thyroid gland. It's those 4 little dots on the back. And that's the hormone that says, I need the calcium back out of the bones, bring it back out of the bones. And so that's how you end up with these mineral and bone disorders as a result of the kidneys not working right. So to remind you, the 3 hormones from the kidney that are produced and released by the kidney, that's renin, erythropoietin, and 1,25-dihydroxyvitamin D, or just vitamin D, activated vitamin D. And that is the end of the chapter on the kidneys. Have a great week.